to the first scientific session of the program. We now have a very, very exciting and interesting session with presentations from both an international and a national expert in the area of gut microbiota. May I request Professor Shinjini Bhatnagar to kindly chair this session, Gut, Its Microbes, Implications for Health. Professor Shinjini Bhatnagar is the Dean Clinical Research and heads the Pediatric Biology Center at the Translational Health Science and Technology Institute in Faridabad. She is a fellow of the National Academy of Sciences and has received several awards, including the Shri Har Bhagwan Kumar Oration in 2012 and Hotam Tomar Gold Medal in recognition of excellent scientific contribution and services in pediatric gastroenterology and nutrition. She has more than 70 publications in international and national journals. Can I request Professor Bhatnagar to invite the speakers and introduce them, please?
Thanks, Nirja. I think they were kind and unnecessary words. Okay, so I'll begin the session taking it closer to what Dr. Ganguly was saying. What are the implications for health with the gut microbiota? And I have the extreme pleasure to invite Professor Patricia Conway to deliver the first keynote lecture. Professor Conway is a professorial fellow at the University of New South Wales, Australia, and chief scientist and director for a biotechnology company. She has 100 scientific papers in refereed international journals, monographs, book chapters, and is an inventor on over 20 patent applications and chief investigator on grants both in Sweden and Australia. Her research interests are gastrointestinal microbiology, probiotics and prebiotics, with particular emphasis on bacterial colonization of the GI tract and mechanisms of bacterial adhesion, pathogen inhibition, and immune modulation in animals and humans. Professor Conway, welcome to India and welcome to the session. We are looking forward to hearing you.
Thank you, Prof. Shinjini and Prof. Ganguly. Distinguished guests, ladies and gentlemen, it is indeed my pleasure to be here today and to be part of this symposium. The program looks particularly exciting. My contribution to the program, I see it as taking you on a journey through life. We talk about microbiota. I want now to classify the microbiota according to the age. So I've structured it such that I'll initially discuss the acquisition of the microbiota in the newborn and factors affecting it. Subsequently, I'll go on to describe the successive development and factors affecting the development. And I would particularly like to thank Professor Nair for his comments on please open your mind, because for many years I would sit and introduce a talk like this and say the intestinal tract of the newborn is sterile. We now know it's not. When I was questioned about breast milk containing bacteria, I would say, you put bacteria and milk together and you get yogurt. Do your mothers express yogurt? So please open your minds. The intestinal microbes of the infant are acquired from the mother during in situ via the placenta and the amniotic fluid. And we've already heard that there are bacteria in these regions. They may be low, but they are there. The mode of delivery is impacting on which microbes are there, and I'll discuss this in further detail. Breast milk. Breast milk is a mechanism for populating the intestinal microbiota of the infant. In addition to these factors, the maternal and environmental contaminants or good microbes are severely impacting on the infant. They're getting their microbes from the hospital environment, siblings, pets. We know that infants that are raised in a farm environment as opposed to an urban environment have a much more diverse microbial population. So let's take that breast milk story a little further and where we are today with it. So here I present data. It's effectively divided into bacterial families on the left and the genera on the right. So we can concentrate just on the families. And it's looking at the composition in the colostrum of, normal weight mothers and overweight mothers in the colostrum 1 month and 6 months of age. Extremely different microbial profiles in the breast milk of those infants. So when we're talking about breast milk, there are different qualities of breast milk. And I'd like that to be an important take-home message. Looking at the colostrum between vaginally delivered babies, non-elective caesarean delivered babies, and elective caesarean delivered babies. They're very different in terms of the microbial profile. The non-elective caesareans have gone through part of the birth process, and the stress compounds that are influencing the microbial composition of the breast milk will be impacting in the non-elective caesarean breast milk. And as Prof. Nair mentioned, how do the microbes get to the breast milk? We believe that during the later stages of pregnancy, the intestinal tract is more porous and therefore more susceptible to microbes translocating across the gut wall via the common mucosal immune system reaching the mammary glands. Looking further at the composition of the breast milk compared to the microbiota of breastfed infants or formula-fed infants. And as you'll see, the population of the milk and the breastfed infant are much more similar. And formula-fed infants, even though formula these days is attempting to simulate the breast milk, we're not there yet in terms of the infant formula. And the formula-fed infants have a microflora more diverse and more liking that of the adult. Looking more at the population of the breastfed infant, we know they're predominantly bifidobacteria, and it's predominantly bifidobacteria in the breast milk. Why that is, The Bifidobacterium longum of infant origin, the subspecies infantis, can utilise the specific breast milk or human milk oligosaccharides. So there's a lot of these very short oligosaccharides in human breast milk, and the frequency of them, the degree of polymerization being smaller. I should not be using the mouse. The degree of polymerization, other strains of bacteria that are being examined for their capacity to utilise the oligosaccharides, and they are of adult origin, they are less likely able to use the oligosaccharides that are in breast milk. Taking the breast milk story one step further in the fact that there's a distinction between the quality of breast milk. Here we're presenting the level of bifidobacteria in breast milk of mothers that are allergic and also have atopic dermatitis, or allergic but no atopy, or healthy mums. And as you can see, there's significantly higher levels of bifidobacteria in the healthy individual, in the breast milk of the mums who are non-allergic and do not have atopy. The combination of the two gives significantly lower levels. And the paternal breast milk bifidobacteria counts have impacted on the infant fecal bifidobacteria counts. And breast milk bacteria are an important source of bacteria for the infant. So let's move on to the factors affecting the infant microbiota. I've gone through where they're coming from. Let's see the factors that are affecting them. Now, I've mentioned the difference between vaginal and caesarean delivery, and with caesarean, I'm referring to elective caesarean here. So during vaginal delivery, we're getting introduction of the normal vaginal microbes, and these are very heavily the lactobacillus. whereas the caesarean delivery is being exposed, it's being delivered in a very sterile environment of the hospital and then exposed to skin organisms and hospital-acquired organisms. So the vaginal leads to a development of the normal gut microflora, whereas the caesarean an abnormal. And the development of these microbes are required for the maturation of the immune system, which is immature at birth and requires the normal microbes to develop the second arm of the immune system required for oral tolerance, to name one of them. So we get normal development of the microbes and the immune system and the proper development of it, as opposed to the caesarean, where there's a disruption, sometimes an unusual or abnormal microflora profile, and there is a significant increase in gastrointestinal, respiratory and allergic conditions in caesarean-delivered infants. Just taking that further and looking at molecular analyses of the microbiota of the mother or the infant during either vaginal or caesarean delivery. And just the fecal microflora, the one circled in red, as you can see, there is a difference in the maternal fecal microflora of vaginal versus caesarean section delivery, and even more dramatic differences in that of the infant. Impact of gestation time. As you can see here, premature infants have a very different microbial profile in terms of the two major groups of organisms compared to full-term natural delivery infants. And even at 3 months of age, the premature infants still haven't yet developed a profile consistent with that of the normal infant. Continuing on the issue, with preterm infants are very predisposed to necrotizing enterocolitis, or NEC. So here we're looking at the profile of the microbes in control infants, are the top two, or those that subsequently developed NEC. As you can see, 1 week prior to diagnosis for the age-matched controls, the microflora profile was dramatically different from that in cases that subsequently a week later developed NEC, and even more so less than 72 hours prior to the diagnosis of NEC in the infants. So there's a strong link between the composition of the microbiota and the incidence of NEC. The previous speaker has already discussed this data, so I won't go into it in more detail, but rather to flag that in addition, diet of the infant will significantly impact on the composition of the microbiota. And I think no study better than this highlights the fact, because there are the dramatic differences in the composition of the microbiota between these two groups of children. I chose this study because I think it shows the impact of medications and diet on the microbiota. So here we have infants that have had initially antibiotic treatment, breast milk for a period of time, enteral feeding, and then formula. And as you can see, there are very different profiles with time as these infants are exposed to the changes in medication and diet. Colicky infants. These too have very different microflora profiles. They have slower colonization to reach a more stable, complex microbiota. They have less biodiversity and less stability. The butyrate-producing species that are required for maturation of the epithelial cells are significantly reduced. There's a change to an increase in the gas-producing and microbes contributing to inflammation. And the known desirable bacteria, Lactobacillus and bifidobacteria, are dramatically reduced. Through the initial 6 months of age, the infant is, especially in the breastfed infant, protected by the mother. So it's receiving passive immunity from the mother until birth, and subsequently if it is being breastfed. At the time of weaning, the infant is getting the reduced protection from the breast milk and from the mother's passive immunity, the microbiota is only starting to develop. The immune system of the infant is gradually developing, and it's not until 6 years of age it's completely developed. At this same time, the infant is exploring, it's crawling, it's putting everything in its mouth it can find. So at the time it has least protection is the time it has maximum exposure. So the gut microflora is really important in facilitating an earlier maturation of the immune system. So if the microbiota has an appropriate profile, the immune system of the infant will be developing more rapidly. That window of sensitivity also correlates well with the increased incidence of diarrhea, episodes of diarrhea in children at the 6 to 11 months of age compared to older or younger. So summarising those facts, this slide is extremely complex, but basically it's taking you through the concepts I've presented, from prenatal birth, first weeks, first months, through to the adult, and the factors that are impacting on the various stages. And if it's a green arrow, it's good. If it's a red arrow, it's potentially undesirable. So you've got the intrauterine contamination. If they're the desirable microbes, it's beneficial. The mode of delivery, we've discussed that in detail. The vaginal delivery has an elevation of the desirable microbes. The age, epigenetics of the mother, the status of the mother is the health and nutritional status and immune status of the mother is particularly important and should not be neglected. The type of feeding we've discussed, we haven't gone into the details of treatments, but clearly if there is a disturbance of the microbiota, systems such as probiotics is beneficial and recommended, whereas medications are going to negatively impact on this. The microbiota of these infants and the impact of early life exposures on the composition of the microbiota we know is contributing to the emerging pandemic of non-communicable diseases, those linked to the immune system, the intestine, and metabolic diseases, as we've heard in the previous, by the previous speaker. So if we target the microbiota through early life exposures and life choices, we can lead to good health as opposed to, and try to reverse the pandemic of non-communicable diseases. Let's move on from the infant to the adult through life. I've chosen this schematic because I think if we just look at the method using 16S sequencing, which are these ones through here, the analyses of the different age groups clearly show by the colour profiles the changes in the population through the development through to the elderly. Dramatic changes, and antibiotic treatment compared to the healthy is different. Malnutrition, very different profile, which we'll be hearing from the next speaker. So looking at that a little bit more schematically, we've discussed the newborn already. Early childhood, there's a rapid increase in the diversity and the early development of the microbiota leads to a maturation of the immune system, but it is particularly unstable, and therefore exposures will influence its subsequent stability. And there are major shifts in response to diet and illness, and we've already shown you the diet. Through to the adulthood, the microbial community is more stable and less susceptible to change, unless there are medications or other complicating factors of stress and lifestyle. Through to the elderly, where there is a substantially different microbiota, less diverse and much more less diversity than the young infant. So this data, the previous speaker has discussed the Firmicutes and the Bacteroidetes, and here we're just presenting the ratio of those two organisms, and the ratio drops dramatically in the elderly. The adults have a much higher ratio, and that elevation of the Firmicutes is linked to an elevation of an inflammatory response in terms of the interleukin 17 with the decrease of the Bacteroides. So let's move on to the factors affecting the microbiota. There are many, many factors, and I felt it easiest to illustrate it in graphics here, but let's just go through the list. Lifestyle choices, medications, diet. Perhaps you can all be thinking about, have you been nice to your microbiota today? And what's it going to do to you subsequently? Stresses, age, institution care or home living, dental health, infections, hygiene, sanitation. Sanitation, we've always, well, in more recent years, we have to be clean. But that in itself is leading to a shift in a less desirable profile and the concepts of eat dirt and be healthy. So sanitation, not necessarily extreme sanitation is beneficial. Urban and rural, another major component. So just some studies highlighting and emphasising that fact. Here is the diversity differences linked to age and culture. So on the left we have, you're right, sorry, we have the age differences and there's the distribution. Clearly the microbiota of the greater than the elderly is significantly different from the younger age. And also culture and origin. USA is dramatically different from the other two countries. Looking at the phyla grouping of the microbiota of the varying ages, this particular study shows the microbiota, the percentages of the different populations in centenarians, elderly and young adults. And as you can see, even at the phyla level, there are dramatic differences between the groups. And that microbial composition by another group of workers has been linked to plasma levels of pro-inflammatory cytokines. The IL-6 and IL-8 are dramatically elevated in the centenarians compared to the young, the yellow, as presented in this graph. Another study looked at the microbiota of elderly subjects based on where they live. And I'm not going to go into more detail than to highlight on this study that the green is those living still in the community, yellow is those, and I'd like you to look at this particular graph as I'm reading out the colours. So green are those living in the community and they clearly are clustered. Yellow are those in day hospital situations. Orange are in rehab situations, so they're overlapping a little with the daycare. And the red and up here are those in long stay care. Dramatic differences in the microbiota of elderly depending on where they're living. And looking at that slide in more detail and that data, here these workers have clustered the microbes according to where the people are living. So the ones on the left are those living in the community, those on the right are those living in hospital care or long hospital care. And it's linked to health indices, and these are the ones presented across the middle. So the health indices of those in care are extremely poor relative to those that are living in the community, which are extremely high. These Wiggum plots are simply all of the microbes that have been identified. There's a disk relative for that particular organism. So the bigger the disk, the more of that particular organism. So really all you need to take out of it is the bigger the disk and the colour is highlighting which particular genus is there. And so clearly the elderly that are in care have a very different, even genus level population of the microbiota. And the discs are representing the number. You can see the number in the centre, that's the number of subjects in each group that was looked at. So the conclusion from this study was that it was clustered according to residents where they lived, and there was a strong correlation with where they lived, their microbiota, and their health status. So in summary, I've discussed this side of the summary, where as age progresses, there's a progression of the microbiota. Many factors are impacting on the microbiota and therefore the health of the individual. So what I hope you take home from today is not only is the microbiota important, but what does the microbiota look like in detail? And it's not just what is there, but it's what it's doing. So metabolomic studies, looking at the metabolites of these microbes, linked with the genetic techniques that we can now drill down and see which particular microbe is there, will give us a lot more information about what is desirable and how we can modulate the microbiota to improve health. Thank you.